Hi, I'm Steve Wooding. I'm the project lead on Mental Health Retrosight. So what we did in Mental Health Retrosight is we tried to understand what benefits research can provide to patients. And we did that by both following research forward and looking backwards from developments in care. Let me say a little bit about how we did the research. So we took 18 pieces of research from the past, from 20 years ago, and we followed them through to the present day. We wanted to understand what had happened to the ideas, what had happened to the people, what impact they were having potentially on patients now. We also took 6 developments or breakthroughs in mental health and followed them backwards to understand where they'd come from, to understand what their research antecedents were. Because our concern was that there hadn't been that many breakthroughs in mental health, and we wanted to make sure we could understand the process from both directions. The next thing we tried to do was to understand what characteristics or types of research are most likely to have that patient benefit. And we split between basic and clinical research. And looking over a 20-year timescale, which is the timescale of the study, we found that clinical research had generally had a larger impact on health than basic research had. And the exact way we defined clinical and basic research wasn't key. We found a similar finding with slightly different definitions. We also tried to look in a bit more detail at the characteristics of the researcher and the researched to understand what types of research and types of researcher are most likely to successfully translate their research. And 2 things came up there. The first of which is that the breadth of the research and the researcher and the research team are really important. So if they're working in different fields, they're working across different stages of the translation pathway, that seems to help facilitate development of the research to patient impact. The second thing we looked at was their motivations. So does it matter why people are doing the research? And although we're slightly cautious about this, there does appear to be something in there where people and researchers motivated by trying to make a difference to patients are more likely to manage that. So I think the results of this study primarily speak to research funders, those people who support research in mental health. And a number of those organisations actually supported this study. So mental health makes up about 14% of the total disease burden across the world. So it's a really important area of health. And one of the striking things about it is there's a big overlap between the symptoms of different diseases. So schizophrenia overlaps with bipolar, overlaps with depression, which means that you can't cleanly focus on a particular area of mental health research. So what we did is we used schizophrenia as an anchor rather than a fence. So we said the research we look at should have a potential relevance to schizophrenia. And that kind of defined the area of research we looked at. A lot of the questions emerging from the study come down to how you implement the findings. So in terms of clinical and basic research, there is a question of how those definitions work. Are there actually different types of basic research? Do we need to understand the different benefits from different types of basic research? There's also a wider question of implementation around how researchers develop as researchers and also in their lives. Can you help them build those bridges across disciplines or across different stages in the translation pathway? Can research funders bring the appropriate researchers together and get them working together productively? Alternatively, it may be a case of identifying the individuals who can do that and supporting them preferentially. So it's a question of, can you grow it or do you have to find it?